once, I'm sure you already took. This is Dr. Blair.
Nice to meet you guys.
Some of you guys we know, some of you we don't. So we're going to talk about prostate health in general. We're going to focus most of the talk on the BPH, what we call the enlarged prostate. Okay. Try to save any questions for the end. We would probably appreciate more general questions as opposed to very specific personal questions in a group setting. But feel free to ask whatever you'd like. Okay, so we're going to first start with an overview of the prostate.
That's a cruel joke.
That's the usual feeling that you really need to try to have in urology. So this is some anatomy that we would like to go over. This is looking at the body on the right-hand part of the screen, looking at the body face on. This is looking at a side view. And essentially you have your bladder over here, and you got your prostate. And the urine goes from the bladder, which is a storage organ, through the middle part of the prostate. There's a misconception often where people think that the prostate has a tube within a tube. And it's not a tube within a tube, it's actually hollowed out. And the inside of the prostate is the channel where the urine goes. The lining of what's called the urethra is actually made of prostate tissue. Okay? The testicles make the sperm, it goes through the ejaculatory duct and empties right into the middle part of the prostate, which is often why when we do prostate work or certain prostate medicines, it affects the ejaculation. The ejaculation comes right over here, and this is the area that you work. Okay, so bladder, prostate, and urine goes right through here. So in general, there are three main prostate conditions that we deal with. The main one is an enlarged prostate, but two other ones are prostatitis and prostate cancer. Prostatitis has different versions of it. The bacterial is the one that people give antibiotics for. Unfortunately, people give antibiotics all too often for prostatitis cases, even though only about 5% of prostatitis cases are actually acute bacterial. The rest of them are either viral or what we call chronic pelvic pain or inflammatory, and there antibiotics don't help. It's really more anti-inflammatories and certain behavioral modification that you can do. Prostate cancer is the number one newly diagnosed cancer in men. It's the second leading cause of death in men. In general, 1 in 6 men are diagnosed with prostate cancer in their lifetime. In 2019, the current year, about 174,000 men will be diagnosed with cancer, and over 30,000 men are expected to die as a result of the disease. The probability of the cancer increases as you age. Between the age of 40 and 60, it's 1 in 103. Between 60 and 80, it's 1 in 8. There are higher rates in African Americans as well as in men with individual family history of prostate cancer, father, brother, even a little bit of uncles and grandfathers. In African Americans, it's not only a higher rate, but it's also found to be a little bit more aggressive when diagnosed as well. I like this slide. I mean, it's an older slide, but it's common men that most of us know or recognize. All have had prostate cancer. It is very common, and it's usual if you're in a group setting that you will know someone or someone's family member that has had prostate cancer, has been affected by it one way or the other. Screening for prostate cancer is still recommended by the Urology Organization. It has led to a lower rate of advanced diagnosis when being diagnosed. So in the past, even 20, 30 years ago, when someone was diagnosed with prostate cancer, it more often, not commonly, but there was a higher rate of it being found at a more advanced level, meaning that it might have even spread locally. And nowadays, that only happens about 4% of cases. And the screening is an annual blood test and a rectal exam. The reason why you need both is there are a certain subgroup of men that have abnormal PSAs and normal rectal exams, and other men have abnormal rectal exams and normal PSAs. Treatment options for prostate cancer, there's an entire spectrum. The one that's not up here because it's not considered a treatment option, but it is an individual option, is something called active surveillance. Active surveillance means it's for low-grade cancers. You decide not to treat it, but you will watch it over time and make sure it doesn't progress to any kind of dangerous level. And then if it does, you go ahead and treat it. And then the treatment options include prostate surgery, which is what we call a prostatectomy, where we remove the prostate, usually using a robotic technique. Radiation therapy, there are a variety of different radiation therapies out there, all of which you've heard on the radio, a lot of marketing for that. And something called ablation technology, which is more of the modern coming of age technology that is available now. It's been FDA approved for a couple years. Insurance approval is still not quite there, although it probably will be there by 2021, with the main ablation therapy, something called HIFU, which uses ultrasound energy to destroy the prostate gland. So Dr. Blair's now going to start us off with the BPH.
Okay, so Dr. Boschko went ahead and talked a little bit about the two other conditions that can kind of go wrong in the prostate, namely the infection, inflammation of prostatitis and the prostate cancer. We're going to talk for the rest of the lecture, the two of us, about enlargement of the prostate. And I would imagine that many of you when you were in high school, never imagined that you'd be looking forward to a Thursday night coming to talk about enlarged prostate many decades hence. But here we all are. And let's start with talking about what BPH means. BPH is an acronym, right? So it's BPH, benign prostatic hyperplasia. And each one of those letters kind of means something. The benign meaning that it's not cancer. B, we're referring to the prostate that we see under the microscope, and hyperplasia, increased number of cells. So this acronym really refers to what the enlarged prostate that we see when we look at under a microscope. But we kind of use it interchangeably with an enlarged prostate. We're going to talk about what BPH is, what it does to the urinary tract, how we diagnose it, and how we can treat it with consideration of the risks and benefits and alternatives of the different medical and surgical modalities. So that's going to be kind of where we go going forward. And as you can see here, there's a number of symptoms that occur as the prostate enlarges. We'll talk about why they occur. Many of you have experienced these symptoms. That BPH, as we're going to talk about, is ubiquitous. It's something that's even much more common than the prostate cancer that Dr. Boschko just described. But increased frequency of urination, usually more than every 2 hours, is considered abnormal. A weak or slow urine flow. I'm sure some of you have gone to a ball game or seen your grandson or son in the bathroom and listened and thought, I remember when my stream sounded like that. It doesn't anymore. Starting and stopping when you urinate. There's a famous line from George Carlin where he says that men over 60, whether or not they served in the military, all tend to have a component of peeing in Morse code. It's that starting and stopping that we get as the prostate gets bigger and starts to block the flow of urine. There is sudden urge to urinate, or what we call urinary urgency. There's painful urination, also known as dysuria. And there's incomplete emptying of urine. These are all symptoms of the enlarging prostate. So aging in the prostate. This is a condition, I like to say that the enlargement of the prostate is almost like a rat's tooth. It just kind of gets bigger as we get older. So, the prostate, by the time you're 60, somewhere around 70% of men having an enlarged prostate, even 90% in our 80s. Some younger men can have a problem with an enlarged prostate, which can be made worse by diet and stress. And the incidence of prostate cancer goes up as we get older. Again, I like that word ubiquitous. It means it's just very, very common, this prostate enlargement. Whereas Dr. Boschko was saying prostate cancer is maybe 200,000 patients or 170,000 patients in a year in the United States are going to have an issue with prostate cancer. In the next year, it's going to be 40 million men that have a problem with prostate enlargement. And this graph over here shows that as we go up in age, in our 50s, 40% of men have BPH, in our 60s, it's 70, in our 80s, it's 90% of men. The quick and dirty rule I like to use is that your likelihood of having a problem with an enlarged prostate is approximated by your decade of life. So 50% in your 50s, 60% in your 60s, and so on. And so the question is, who designed this thing? Why did that happen, right? I mean, why do we get an enlarged prostate? And the real truth is that we don't really know. The prostate's an organ that responds to steroid hormones, testosterone. It's a reproductive organ, kind of like the uterus and the breast and some of these reproductive organs. There's an interplay of hormones and receptors that occur after we're past our reproductive years that we believe that, along with genetics and other factors, result in this process of the prostate just getting bigger as we get older. So exactly what's going on and why do we care that the prostate gets bigger? So what this picture is trying to show here is this is what's called the coronal section, and this is what's called the sagittal section. So I want you to kind of imagine, you take a big knife, and you cut me right through my ears all the way down to my feet, and then you strip the middle part of me away, you'd be looking at a coronal section. So if you strip the middle part away, you'd be looking at the bladder here, and then there's the prostate, okay? Think of this here as your 20-year-old self, and this is more like your 70-year-old self. So when you're 20, you have this nice smooth-walled bladder with a nice wide caliber channel running through the donut hole, the center of the prostate that Dr. Bochco described. You can see the same thing in the sagittal section. Urine's gonna come out, high flow, low pressure, and you're gonna empty completely. As we get older, the enlargement of the prostate, depending upon how it grows, we'll talk about that, if it grows inwards as opposed to outwards, compresses that channel, that urethra. And as it does so, it becomes harder to get the urine out. Some of you may be familiar with physics and Ohm's law. You know, there's sort of a physics of flow, where the flow is gonna be directly proportional to the squeeze of the bladder, inversely proportional to the resistance of the prostate. So as the resistance of the prostate goes up, the only way to get the urine out and not go into renal failure is for the bladder to squeeze harder. That harder squeeze is good because it gets the urine out in the short term, but in the long term, those high pressures are detrimental and they can actually damage the bladder. You can see here, this bladder is kind of ugly. It's got these trabeculations, it's thickened. You don't want to be buff, you don't want your bladder to be buff, you may want your muscles to be buff, but you don't want your bladder like this, because when that happens, the bladder doesn't store the urine well at low pressures, and also the muscle begins to be replaced by scar tissue, such that eventually that bladder loses its ability to contract. And in the worst case scenario, you can end up with what we call a flaccid bladder. A bladder that is so damaged from the high pressures that it can no longer mount a contraction, and you're stuck wearing a catheter, or you have a big problem. So that's one of the main things we're really trying to avoid, is that end organ damage that can occur with prostate enlargement. We care about the quality of life and the symptoms, but we really want to avoid the worst case scenario where you could damage your bladder, hurt your kidneys, get an infection, get a stone. So that's really what we're talking about. Now this is another picture that just kind of shows that. This is sort of a worst case scenario bladder. If we wait till this happens, we're in trouble. We don't want to wait until you can't get the urine out and the bladder's damaged and it doesn't work anymore. So this is what happens when someone doesn't have a problem addressed that they should have had addressed long ago, and that deterioration of the bladder is one of the main things that are first and foremost in our mind in trying to prevent when someone has prostate enlargement. This kind of shows the progression of prostate enlargement as we get older. So here's that 20-year-old guy with a nice wide caliber channel. Again, this is the sagittal section. The urine's coming out high flow, low pressure. This is what it would look like when we look in with a telescope. This black area here is empty space looking into the bladder. There's plenty of room for that urine to come through. And 20 years later, the prostate's bigger, it's growing inward and blocking the flow of urine here. You can see when we look in through the cystoscope here, these lateral lobes, these sidewalls are starting to come together, creating less space, making resistance, making the bladder work harder. And then you can see here, 20 more years later, the prostate's so big, the lateral lobes are kissing or clapping, it may be impossible for any urine to get out. So how do we make this diagnosis of an enlarged prostate? Well, as we do with most medical conditions, it's going to be a combination of a history, a physical exam. We have some other specialized tools. We have some surveys, some questionnaires that you can fill out. One is called the AUA symptom score, where we ask you questions and we ask you how much those symptoms are bothering you. We can sort of stratify you into groups of mild disease, moderate disease, and severe disease. We also have specialized testing, including ultrasound of the bladder, ultrasound of the prostate, cystoscopy, where we look inside the bladder, a procedure where we're measuring the flow rate as the urine comes out. Remember I said that the flow is going to be directly proportional to that squeeze, inversely proportional to the resistance. We can do this in a very accurate, sort of detailed way. We can do it in a non-invasive way. These are called uroflowmetry and urodynamics. So, and then the other point here that we like to make is that understanding this, there's a little bit of subtlety to it. You might think, well, the bigger the prostate is, the bigger problem I have. That's not actually true. We talked about some prostates can grow outward and the channel remains widely open and there's not a problem at all. You might think, well, if I have a small prostate, I'm fine, I don't need to worry about it. And that's not true either, because sometimes small prostates grow inward. Additionally, our fingers are not so great at telling us how big the prostates are. And then to make it even more sort of complicated, some people have tremendous obstruction, but it doesn't really bother them that much. And so the degree of obstruction doesn't really correlate with symptoms. So there's a lot of subtleties that we have to think about. And what we're going to get to is that there's not one size fits all when it comes to treating prostate enlargement. We have to really balance what's going on with the patient anatomically and physiologically, along with what matters to you and how much something bothers you. These are all considerations that we want to put together and make a shared decision about. The other thing that we're doing with this physical exam and history is that although enlargement of the prostate is this ubiquitous, very common problem that usually explains the getting up at night and the frequency and the urgency and the running to go to the bathroom, there are other reasons this can happen. And we have to rule out other causes. Things like scar tissue in the urethra and the infection and inflammation that Dr. Boschko described. Bladder cancer, which is the fourth most common malignancy, can sometimes present with frequency or urgency of urination, not to mention the blood in the urine. And bladder stones can similarly present this way. Medicines, including decongestants, which are commonly taken for colds in the spring when there's a lot of pollen, or antihistamines can affect the way we urinate. Other medications can have side effects. Neurologic conditions, strokes, and other neurologic conditions can also be the reason why we have these lower urinary tract symptoms, and those are causes that need to be evaluated so we can really nail down that diagnosis that what we're dealing with is prostate enlargement and not something else that needs to be treated differently. Now this slide, this is kind of an important slide. I like to emphasize that sometimes things happen so slowly in life that we don't even know that they're happening. You know, sometimes maybe looking at yourself in the mirror for 20 years, and then you go to your reunion, you're looking around the room thinking about how old everybody is, and they're looking around the room thinking how old everybody else is, but you don't think you changed, but you have. The way we urinate, sometimes it changes so slowly that we don't notice it. And it's not an uncommon condition that somebody will present to see us, and they don't even think they have a problem. They may be getting up 3 or 4 times a night, and they think that's normal. The urine, it may take them 4 times as long to empty. They may have pain, they may be starting and stopping, but this silent prostatism, silent BPH is the danger where, yes, we want to improve people's qualities of life, but in the worst case scenario, an enlarged prostate can damage the bladder, can damage the kidney, can cause infections, can cause stones, can cause bleeding. There are cases where it even puts people on dialysis. So we really want to be careful that, first and foremost, we don't allow that to happen. So that we call it silent prostatism. Now, in a minute I'm gonna let Dr. Boschko take over. So one of the ways we try to prevent this and both improve quality of life is, being somebody who's in the military, I like to think of this as our armamentarium, right? So over on this end of the armamentarium, we have the least invasive options to fix the problem. And on this end of the armamentarium, we have the most effective and most invasive options. You don't get least effective, least invasive, and most effective. The least invasive is also the least effective, and the most invasive is also the most effective. So we have this armamentarium of things that we can do to fix this problem. And kind of going from left to right, we can just keep an eye on it, what we call active surveillance. There are medications. Dr. Boschko is going to talk about the 2 main classes of medications that shrink the prostate by different mechanisms of action, the alpha blockers and the 5-alpha reductase inhibitors. There are these minimally invasive therapies, and these is one category that just keeps getting better. As technology gets better, and this is true for cancer therapy or a lot of things in medicine, we keep trying to do the same things with lower risk, get the same efficacy with less morbidity. So some of these minimally invasive therapies, they're better than medicines, not quite as good as radical surgeries, and 2 of the newer ones that we're going to talk about are the resumed procedure and the urolift. And then way over here on the right are really sort of the real thorough roto-rooter jobs. The TURP, the laser TURP, and the suprapubic prostatectomy. We're really opening up that channel, making that donut hole really big. And some people just really need that. So I'm gonna let Dr. Boschko take over, talk a little bit more about the urolift, and I'll come back and talk to you, and at the end we'll open up the floor for questions.
So just as a quick review before we go into the treatment options, what we're trying to get at is there are a couple of factors we look at when you assess somebody. Okay, I like to always say there are these subjective issues. That's what Dr. Blair said, the AUA symptom score, basically how a person's quality of life gets impacted, whether it's frequency of urination or having to strain to get the urine to come out, or whether other things of the list that he presented. Those are the subjective issues, or the subjective complaints that a person has. Then there's the objective, meaning medically. So what Dr. Blair was talking about was the silent BPH issue, that's something that we have to, as urologists, have to be concerned about, is the long-term damage that the enlarged prostate causes to the bladder. And that's what all the extra testing that we do in the office allows us to do. Because if you just go by someone's symptoms and you base all your treatment based on that, you're gonna miss a lot. You're gonna miss bladder damage. You might treat somebody for something and you're treating them for the wrong issue. There's a lot that goes into it, and that's why we really say that we try to individualize the diagnosis and you have to individualize the treatment. It's not a one-size-fits-all disease. In fact, you can have two different prostate patients, same exact prostate size, but have two completely different scenarios. You really have to, you can't just say this is the prostate size, these are his complaints, and here, this is what you do. So that's where sitting down and kind of trying to figure out all these factors come into play when you're in the office and trying to see what your options are. Okay, so what Dr. Blow was saying, again, the treatment options, they run the spectrum from the least invasive, which is watchful waiting. Then we go up to medications or herbal remedies. There's something called the Urolift, or the official name of it is a prostatic urethral lift. That's the least invasive of all the procedures. Then there's the thermotherapies. The main one is the Resume. And then there's more of the surgical therapy, which is laser TURP. Otherwise, some of the people know it as a green light TURP, but there are about 6 or 7 different lasers out there now that different urologists use. They all accomplish the same thing, which is basically laser vaporization of the prostatic tissue that's blocking up the bladder. And then the TURP is the good old-fashioned standard roto-rooter, where you go in and you literally take a U-shaped wire and you scoop out the prostate tissue. So watchful waiting, the advantage is very obvious. You don't do anything. There are no medicines you have to deal with. There are no procedures you have to deal with. There are no side effects. That's simple. But obviously the disadvantages are you're certainly not going to get any better. Your symptoms aren't going to improve. In fact, if your symptoms improve, more often than not, that actually means that you're actually doing worse. Because if your bladder gets weaker because of consistent obstruction to the bladder starts to lose sensation. So all this urgency and frequency that someone might complain about initially, all of a sudden they say, hey, years gone by, I'm feeling a lot better. I don't have to go to the bathroom as often. It's not because they're doing better, it's because their bladder is weaker and doesn't feel what it should feel. So it doesn't give the signal to the brain to tell you, hey, you're having an issue. So symptoms certainly don't get better on watchful waiting. Symptoms don't get worse, and if they get better, sometimes that's an indication of more progressive disease than you would otherwise think. Medications, so the two main categories are alpha blockers. Alpha blockers, if we go back to the picture of the prostate, so you have muscle, I'll go to this side this time, you have muscle that surrounds the prostate tissue itself, okay? That muscle is tight, and these alpha blockers, so they're called Flomax, Rapaflow, Hytrin, Cardura, Doxazosin, Tamsulosin, Silodosin, trade names, generic names, you name it, they all do the same thing, and they relax the muscles on the outer part of the prostate, okay? If you're able to relax the muscles in the outer part of the prostate can expand outwards. And so the inside channel where the urine goes opens up, and then you get a better flow as a result of it. Because as the prostate moves out, the inside channel where the urine goes opens up, and that's what those alpha blockers do. Then there are something called 5-alpha reductase inhibitors. The main two, the old names of them used to be Proscar or Avodart. We still refer to it as that. But the generic names, which is what we use now, are finasteride and dutasteride. And what those medicines do is they try to shrink the prostate. And by shrinking the prostate, again, the urinary channel should open up. Now, the one thing you should know is you should say, oh, shrinks the prostate, that's it, it's a nice easy fix. The problem is that it doesn't necessarily work in a targeted fashion. So again, if you go back to the picture here, if you go ahead and reduce the prostate, but it's being reduced out here, well, the inside channel where the urine is going is still congested. So just because you reduce the overall size of the prostate doesn't always translate to the inside channel opening up. It does more often than not, but not as much as you would think in terms of shrinking of the prostate size. And then people are familiar with saw palmetto. Saw palmetto is what we call phytotherapy and nutraceuticals. Those are herbal supplements. We don't have any issue with people taking them, but the long-term studies really don't show any objective benefit of using saw palmetto, but there's no harm done. So if someone thinks that it's helping them, well, again, just because it doesn't help somebody else, maybe it still helps another person. So if you're taking saw palmetto, that's certainly okay to continue. The problem is I wouldn't just rely on that as a treatment option. The medication advantages are that you don't have to undergo any procedures. You certainly can get symptom relief by opening up the urinary channel. The disadvantages are, well, you have to continue with the medicines. The medicines do have side effects. The alpha blockers can cause sometimes nasal stuffiness. Every now and then somebody brings about sleep disturbance. The main one is lightheadedness or dizziness, something called orthostatic hypotension. Essentially is that you get dizzy when you're on the medicine. They can cause ejaculatory dysfunction. Really more of an issue for younger men who might want to preserve fertility, but certainly it's also even for older men who want their full sexual function. When you ejaculate on these medicines, sometimes the ejaculate volume dries up and nothing comes out. Okay? The 5-alpha reductase inhibitors, the ones that shrink the prostate, they have more of a hormonal side effect profile. They can cause breast tenderness, breast enlargement, decreased sex drive, erectile dysfunction, all these hormonal side effects that are associated with that medicine. So there are definitely side effects. They do have good efficacy, but they are limited. There's only so much help that the medicines can accomplish. So depending on, again, that's where you have to tailor the treatment to the individual, depending on the degree of obstruction, not the degree of size of the prostate, because like Dr. Blair said, sometimes you can have a really big prostate and have no obstruction, and you can have a really small prostate and have a full-blown obstruction. So you always have to keep that in mind. So in terms of the procedures, the one that we're going to start off with is the urolift, which is called the prostatic urethral lift. And out of the therapies, it's the least invasive. But with the least invasive, it's probably the least effective. It's still effective. The studies show good 5-year efficacy, but you're not getting rid of prostate tissue. So what you do is, let's go to this and we'll go back. So what you do is, again, if you think about the prostate, squeezing the urinary channel, okay, you put the cystoscope inside, and then you deploy a curved needle. And it has it's almost like, I always like to say it's like a Broadway show. And the curtains are closing in on the show. And you're going in and basically pulling the curtains back and roping something around it and keeping the curtains out of the way. And that's what you're doing with this. You're putting the needle in, the implant, okay? And you take the scope and you push the prostate outwards, out of the way, and then this implant keeps it out of the way. And that's all the system is. That's all. It's very straightforward. It accomplishes a lot. So essentially, you do it depending on the length of the prostate. There's a certain amount of clips or implants that you place, and it just pushes the tissue out of the way and opens up the check. That's what it is. The nice thing about this procedure, obviously, it's the least invasive. It's done in the office. Very often, it's done under a local, meaning you don't need to have any anesthetic risks. Go to your internist for clearance and blood work and so on and so forth. Usually you get some Valium, you get a prostatic block. There are times when we do it under anesthesia, but it often is done under a local. The nice thing about it is it really does preserve sexual function. Ejaculation should be preserved, erection should be preserved. The studies show about a 5-year lifespan. In terms of how you feel afterwards, so it says typically no catheter. There's usually a catheter left in, but only overnight. That's the one. It's the procedure that requires a catheter the least amount of time. Usually overnight, and usually the main complaint is some burning on urination for anywhere between 3 to 7 days. That's relieved by a medicine called Pyridium, which makes the urine turn orange. You could get a little bit of extra urgency and frequency afterwards, but not as much as some of the other procedures that are out there. Blood in the urine certainly is expected. That's, again, any procedure that we do. Once you're disturbing the architecture of the prostate and doing something to it, it bleeds. Just like if I took a needle and put it on my hand and pinpricked it, it bleeds. But it's usually nothing of any significance. This is what the implant looks like. The part that is curved on the top part over here is the part that's going in the inside to the capsule of the prostate on the outer rim of the prostate, and then this is the part that is on the inside of the prostate, kind of keeping it at bay. It's made of nitinol. If anyone knows what that is, you'll let me know, but it's a certain kind of metal. The benefit of the UroLift, as opposed to the other minimally invasive procedure that Dr. Blair will talk about, which is the Resume, is that the UroLift is immediately effective, because you're pushing the tissue out of the way and you get that immediate benefit. So if you look on the right side of the screen, you have the upper picture shows the lateral lobes of the prostate, like Dr. Blair was saying, is squeezing the urinary channel. And then once the tissue is pushed to the side, the right lobe gets pushed to the right, the left lobe gets to the left. You have an open channel, and you can see that you have a nice channel to urinate through. So you see it right away. The implants are placed in a certain location. So if you imagine a clock, it's basically between 2 o'clock and 5 o'clock, or 2 o'clock and 4 o'clock, depending on the anatomy of the prostate. So it stays away from sort of vital structures, and that's why you don't have the side effects of significant bleeding or the ejaculation issues. So Dr. Blair is now going to talk about the thermotherapies, the Resume being one, and then the surgical therapies.
Okay, so we're kind of, again, moving along our armamentarium here. Remember, these are the least effective, least invasive, and here we got most effective, most invasive. We just talked about the UroLift, which is generally a little more efficacious than medicine, slightly more invasive. Now we're getting over to treatments where instead of plicating or sort of pushing the tissue out of the way, we're actually removing tissue. And the least invasive way to remove tissue fits into this category called thermotherapies. The older thermotherapies would heat the prostate with radiofrequency energy or microwave energy. The newest kid on the block is this Resume procedure, which actually injects steam into the prostate, which is definitely more effective. Some of the advantages of this Resume procedure that we're going to look at in a minute are it can be done in the office. It can also be done under sedation, although we do offer both, a light anesthesia, which many patients prefer. It's paid by many insurers, but not all. Compared to, say, a laser TURP or a TURP, which is, the procedure is further over here, it has fewer side effects. Disadvantages is, unlike the UroLift, you do need a catheter, usually for at least 2 days with this procedure. And I like to say you kind of get a little worse before you get better. With the Resume, it's almost like someone punches you in the eye and your eyes swell shut, you gotta wait for the swelling to go away before you can see. When we inject the steam into the prostate, initially there's a lot of swelling, and we have to wait for that swelling to dissipate as the inflammation resolves, and wait for the tissue to slough off, such that sometimes it's 3-4 weeks before you start to get better than you were before the procedure. So this is kind of a cartoon for how the Resume works. This is showing it kind of happening in real time, but in reality, the steam is injected and the tissue doesn't just go away immediately, it has to slough off over time. But you can see here there's a telescope or a cystoscope inside the prostatic urethra. Steam is being injected, it's injected to both sides. The number of injections is again tailored to the size and anatomy of your prostate. And in the end, when you're all healed, you have this nice wide open atrium or defect or channel that's going to create less resistance and get you urinating a lot better. I have been really impressed with the Resume procedure. It is doing things that the other thermotherapies never could. And I'm seeing patients that have their flow rates double and really get to 20-year-old flow rates with the Resume. So I'm a big fan of the Resume procedure that we've been doing quite a lot of. Neat thing about the Resume is it's really quick and easy and safe. It's a 5-minute procedure. It takes maybe 10-minute procedure. You get either some light conscious sedation like you would get for a colonoscopy, or it can theoretically be done under a local. There's no risk of erectile dysfunction. I would say 5 or 10% of people can complain of having less ejaculatory volume. As we're going to talk about with the laser TURP and TURP, some of the semen can go backwards into the bladder when we open up the channel. But that's a rare complication, I would say 5 to 10%, but again, it doesn't affect your erections in any way. And usually you're out a couple days while the catheter's in, so if you did it on a Monday, take the catheter out Wednesday, usually back to work Thursday, something like that. Now, again, we're kind of moving all the way over to the right side of that armamentarium. Let me kind of go back so here's that armamentarium. Now we're going to talk about the most effective treatments and unfortunately the most invasive treatments. And some people really need these based upon their anatomy and their condition. The first one we're going to talk about is the good old TURP. TURP stands for transurethral resection of prostate. This procedure has been around longer than I've been alive. This procedure is, for 75 years was the standard of care, and as Dr. Boschko described, it involves a full anesthesia. It used to be the most commonly prescribed, for many decades, was the most commonly performed surgery in hospitals in America. It no longer is now that we have other modalities, but it involves a full anesthesia, cystoscope in the penis, removing tissue with a loop with electricity that runs through it. It's very effective in creating a wide open channel that has a very well-proven improvement in the force and caliber of your stream and your symptoms. The downside, of course, is that you're in the hospital for a few days. It has the highest risk of bleeding. There's a small risk of injuring structures nearby, including the sphincter that holds the urine in. That's very rare. Risk of permanent incontinence and erectile dysfunction are still very rare. This is still, considered a endoscopic procedure. We're not opening you up, but it is, of the procedures that we've discussed, at the more invasive end of that continuum. The laser TURP is something that's been around for a couple decades now, and it really is accomplishing nearly the same results as the TURP in a less invasive fashion. In fact, the vast majority of laser TURPs are done as an outpatient procedure, meaning you go home the same day, as opposed to needing to spend time in the hospital with irrigation of the bladder with a TURP. It takes about an hour. The TURP and the laser TURP, one of their big advantages, in addition to a more profound improvement in the force and caliber of your stream and symptoms, are that they have a more durable response. Dr. Boschko alluded to the fact that with a Urolift or Resume, you might get 5 years, 7 years if you're lucky, before the prostate grows back. All these procedures are kind of like giving the prostate a haircut. This is more like a crew cut with the TURP or the laser TURP, and so you're going to get a good 10 years mileage out of the TURP or the laser TURP. The big downside to the laser TURP in my mind is that it uses laser energy. We're going to show you a video of how it's done, and it's very hemostatic, meaning there's almost no bleeding, but the price that you pay for that hemostasis is that there's a slightly increased risk of scarring with a laser TURP. Now this is a neat slide, just to show you again how really what our goal is to sort of, we have all these clubs in our golf bag, and we want to pick the right club for the right shot. We have to pick the right procedure for the right patient, the right symptoms, the right prostate, the right anatomy, the right physiology. And so here are some different prostates. If you look at this one over here, this is a relatively small prostate, not so much obstruction, kind of a high median bar. This is someone that might do well with observation depending upon their symptoms, might do well with medications, might do well with a Urolift or a Resume. Probably wouldn't want to do a more aggressive procedure on than that, but theoretically you might. This is someone who has very large lateral lobes, no median lobe tissue. This is someone who, again, might need some medicines, might do well with the Urolift, might do well with the Resume, could have a laser TURP or a TURP. This patient over here, very large median lobe, which is a protrusion of prostate that's sticking into the bladder almost like a tongue. This is problematic because medicines are not going to work for this. Observation's not going to work for this. Some of the minimally invasive therapies you could theoretically try, but probably you really need a TURP or a laser TURP to address this median lobe. Now this patient has the worst of all worlds, a really large median lobe, large lateral lobes. He's probably going to be best suited by a TURP or a laser TURP. And again, what you're looking for is tailoring the treatment to the anatomy, physiology, and what your wants, needs, and desires are. MIT again stands for minimally invasive therapy versus laser TURP versus TURP. We're trying to kind of show you how we come to those decisions. Getting back to the laser TURP,